A very good morning to everyone. Today, I would like to present my clinical practice case study presentation. Without further ado, let us go to the second slide. Okay, the topic today is the assessment and management of medical patient, acute exacerbation bronchial asthma secondary to community acquired pneumonia with retroviral disease. All right. Okay, for the introductory. So as we know, asthma flare-up when happens when the airway get all inflamed and overreact. Well, things can get lots worse when community-acquired pneumonia step in. It can trigger a massive immune response, causing bronchospasm, tons of mucus, and a serious drop in oxygen level, which obviously not a great condition. And the trouble doesn't always stop after the infection clears. Turn out about 68% of people who recover from CAP still deal with lingering lung inflammation, which can make breathing problems stick around for the long haul. All right. Now, if someone living with HIV or retroviral disease, things can get even trickier. The immune system is already compromised, making them way more vulnerable to bacterial disease infections such as Streptococcus pneumonia and Haemophilus influenza. And then there are opportunistic infections, stuff like PJV or CMV pneumonia, which can be life-threatening. So yeah, it's a very tough situation. That's why managing these cases properly is super important because it's not just about treating one infections, it's about keeping the whole system in balance. All right. So when someone get community-acquired pneumonia, their immune system kicking into high gear, releasing a bunch of cytokine, things like interleukin-1, interleukin-6, or TNF-alpha. The problem, while this response fight of this infection, it also causes inflammations and lung damage. Now, with asthma, it's a little bit different, but still tied to inflammation. The airway already hyperactive. So when they get triggered, they release histamine, which lead to swelling, narrowing of the airway, and way too much mucus productions. It's a really bad cases, whether it's CAP or asthma. Patient can up with a hypoxemia, carbon dioxide retention, and even respiratory failure. That's when things get serious, and patient need aggressive intervention to avoid crushing. In HIV, chronic immune activation, ongoing inflammation, and microbiome imbalance all contribute to the acceleration of lung function decline. Over time, this increases the asthma-like symptom and even COPD. When it comes to managing these patients, things can get tricky. Severe infection often need more aggressive treatment, meaning to say that stronger antibiotic, antifungal, or antiviral. But on top of that, there are HIV specific issues to consider as well, such as antiretroviral therapy, immune regulation, and keeping the microbiome in balance all play a huge role in overall lung health. That's why when a RVD patient with CAP or asthma exacerbation is really straightforward. We are dealing with airway hyperresponsiveness on one side and immunosuppression on the other side. So the treatment has to be targeted and carefully balanced. So this is my case study. For patient background, this is a 26 years old Malay from Kampung Bako, Hile, Petrajaya, Kuching. He's a single and live with his parents. He's a very active smoker and vapor, and with a history of childhood asthma. He still uses MDI salbutamol to puff as needed and often require nebulization in clinic kesihatan. His asthma tends to flare up with URTI, cold exposure, and dust. He was diagnosed with HIV in August 2024 with initial CD4 count of 712. His HIV polymerase chain reaction test on August 7, 2024 show no detectable viral load. He currently on Tinovavi, is a very difficult to pronounce. It just said 10 m, one tablets once daily, and evaference 600 mg one daily. He came to ED with shortness of breath, cough, fever, and pleuritic chest pain for the past 2 days. He first saw a GP where he was given two nebulizer treatment, but he reminded tachypnic with respiratory rate of 50. His oxygenation was 80% on nasopron oxygen. When he got to emergency department, he was really struggling, only able to speak in a short word instead of full sentences. His respiratory rate was 50 breaths per minute. His heart rate was 145 beats per minute, and his blood pressure was 144 over 81 millimeter mercury. And even with oxygen support, his oxygen saturation was only 85%. They did a quick bedside chest X-ray, which showed haziness on the left side, suggesting pneumonia. His arterial blood gases analysis confirmed things were not looking good. And then his pH was 7.17, indicating acute respiratory acidosis. His partial pressure of carbon dioxide was 72 millimeter of mercury, showing he wasn't ventilating properly. His bicarb level was 26.3, so there was no metabolic compensation yet. His partial pressure of oxygen was 68, reflecting mild hypoxemia, and his lactate was 2.7, which pointed to some metabolic stress or tissue hypoxia. In short, he was in acute respiratory failure, most likely due to pneumonia, and needed urgent respiratory support. Looking at his arterial blood gas result, it seems he's dealing with acute respiratory acidosis, which could be from severe asthma exacerbation, pneumonia, or even the start of respiratory failure. When we consider different possibility, we're looking at the severe lung condition as a community acquired pneumonia, acute respiratory distress syndrome, or even a chronic obstructive pulmonary disease exacerbation. There are also the chance of that airway obstruction, like in the status asthmaticus, is playing a role, leading to hypoventilation and subsequent carbon dioxide retention. Assessment and finding. As for clinical condition, we got a severe acute exacerbation of bronchial asthma. Already a very tough situation, but on top of that, the patient also have pneumonia and a fungal infection in the perineal and groin region. Now, here's the problem. Even after nebulization, the patient still persistent rhonchi or wheezing sound. That's a big red flag, okay? Because it means the airway obstruction is still pretty bad. This isn't a mild flare-up. We are looking at a case that might need more aggressive treatment, maybe even ventilatory support if things doesn't improve. So for the laboratory finding, the patient white blood count is significantly elevated at 24 billion per liter, which strongly indicated an active infection or inflammation. Given the clinical context, this elevation is most likely due to bacterial pneumonia. Through further differentiation of neutrophil and lymphocyte count would provide additional clarity. Liver function tests show that total and direct bilirubin level are within normal limit, indicating no significant liver dysfunction or red blood cell breakdown or hemolysis. Additionally, albumin, globulin, and albumin to globulin ratio are all normal, ruling out any sign immune system abnormality or axis inflammation. The liver enzyme level, ALT, AST, and ALP are also within the expected range, confirming that liver function is intact with no evidence of hepatocellular damage or bile flow obstruction. The patient blood glucose level is 9.5 millimole per liter, which is mildly elevated but not critically high. This increase could be a result of a stress-induced hyperglycemia. It's a common occurrence in critically ill patients or side effect of medications such as corticosteroid or bronchodilator. Regular monitoring will be necessary to prevent further metabolic complication. Lastly, electrolyte and mineral level. including calcium, magnesium, and phosphate, are all within normal limit. This indicates a stable metabolic status with no immediate concern regarding electrolyte imbalance. For clinical implication, the elevated white blood count combined with diagnosis of pneumonia indicates an ongoing infection that requires close monitoring. Appropriate antibiotic therapy should be continued or adjusted based on patient response, and any additional microbiological finding. Ensuring adequate infection control is priority to prevent further complication. Ensuring adequate infection control is priority to prevent further complication. That is a must. Okay. The persistent airway obstruction, despite initial nebulization therapy, suggests that the current treatment is not fully effective. This means we need to intensify bronchodilator therapy and consider escalating to ventilator support if the patient respiratory status worsen. Close monitoring of respiratory effort, oxygenation, and response to therapy will be a guide for the intervention. And while the blood glucose level is not critically high, it is still elevated, possibly due to the stress reaction or medication, as I mentioned before. Regular close monitoring is essential. Okay. On the positive note, liver function and metabolic panel results are stable, indicating there are no signs of additional organ dysfunction. This is reassuring because it means that we can focus managing the primary issue, which is a respiratory distress and infection, without concern about liver impairment or metabolic instability. So the final thought, the key priorities in this case are aggressive airway management, infection control, and continuous monitoring of both respiratory function and metabolic parameters. The laboratory finding help us to pinpoint the primary concern, the lungs and the infections, while reassuring us that the other organ system remain stable. So here is the fun part when the patient was managed systematically at the 3 different places to continue their comprehensive and holistic care. At ETD management, the patient was intubated due to the severe shortness of breath, persistent wheezing sounds, and dangerously high carbon dioxide level. This symptom indicated significant airway obstruction, making immediate intervention necessary to stabilize breathing and prevent further deterioration. For the intubation, a 7.5mm endotracheal tube was inserted and secure placed at 22 cm using a video laryngoscope (CMAC). This method ensures proper placement and minimize complication during the procedure. To keep the patient comfortable and prevent agitation, the intravenous fentanyl at 100 microgram per hour and midazolam at 10 mg per hour was administered for sedation. This helped to maintain adequate ventilation while preventing distress. Initial treatment focused on addressing both airway obstruction and underlying infections. Nebulization therapy was provided to open up the airway, while intravenous augmentin was started to treat the suspected pneumonia. Intravenous fluid with potassium supplementation was given as needed to maintain hydration and correct electrolyte imbalance. To further management, several investigations was performed. Blood tests, including C-reactive protein and blood culture, were taken to assess the extent of infection. An endotracheal aspirate culture was sent to identify potential respiratory pathogen. A chest X-ray was conducted to evaluate lung involvement and rule out additional complication. Given the severity of the condition, the patient was referred to the ICU for ventilator support. The respiratory team was involved to ensure close monitoring and further treatment adjustment as needed. This comprehensive approach ensures that the patient receives immediate respiratory stabilization, infection control, and continuous monitoring in a critical care setting. For ICU management, the patient was then admitted to the ICU for 4 days with a life-threatening asthma attack that was worsened by a community-acquired pneumonia. His condition was critical. He was struggling to breathe due to the severe respiratory distress and worsening carbon dioxide retention or hypercapnia. Because of this, he had to be intubated and placed on mechanical ventilation at ED by NS team. After intubation, his arterial blood gases result were alarming. His pH was 7.5, indicating severe acidosis. His PCO2 was extremely high at 92 millimeter of mercury, meaning he was retaining too much carbon dioxide. On top of that, his partial pressure oxygen was only 31, showing dangerously low oxygen level. To manage this, they placed him on ventilator using synchronized intermittent mandatory ventilation mode, SIMV. They set his FiO2 at 0.8 or 80% of oxygen to improve oxygenation. He and used a positive and expiratory pressure at 7 centimeter water to help keep his lung open and reduce carbon dioxide retention. To help with mechanical ventilation and reduce respiratory muscle fatigue, the patient was given IV rocuronium for neuromuscular blockade from day 1 to day 3. This helped him to breathe more effectively while on the ventilator. Several supportive medications were also started. IV pantoprazole 40 mg once daily was given to prevent stress ulcer. IV thiamine 200 mg twice daily was added for nutritional support. His prolonged immobilization increased the risk of blood clots. He was given subcut caxin 40 mg once daily for thromboprophylaxis. To manage his asthma and airway inflammation, he was treated with IV hydrocortisone 100 mg 3 times daily and MDI budesonide 1 puff twice daily. Since his pneumonia was suspected to be bacterial, he was started on IV augmentin 1.2 gram 3 times daily for 3 days. By day 3, he was also given oral azithromycin. Azithromycin to provide additional coverage for atypical bacterial such as mycopneumonia. Okay, despite its initial concern for bacterial infection, the culture result was negative, showing no significant bacterial growth in his urine or endotracheal tube sample. All right. Extubation and recovery. By the 4th day, our patient showed a significant improvement. Successfully extubated. At the time of extubation, his vital sign was stable. His blood pressure was 111 per 98 millimeter of mercury. Heart rate was 87 beats per minute. And his oxygen saturation was 97 while on venturi mask, delivering 40% fraction of inspired oxygen. He was breathing comfortably, not showing any sign of tachypnea, and remained hemodynamically stable without requiring inotrope support. He tolerated oral intake very well and maintained adequate urine output 50 to 60 milliliter per hour. And it is indicating a very good renal function. His temperature was 36.7, no fever. On lung auscultation, we still heard a scattered wheezing, which suggested persistent airway inflammation and mucus purging. Because of this, he required continued bronchodilator therapy and chest physiotherapy to help clear his airway and improve his recovery. So after the 4 days in the ICU, the team planned a smooth transition for him back to the medical ward. The first step was gradually returning to oral intake, which meant removing NG tube once he tolerated eating and drinking on his own. Next, the central venous line was removed before transfer to reduce the risk of infection. Since he still needs some respiratory support, he continued on oxygen therapy via venturi mask to maintain adequate oxygenation. To help with his airway clearance, he was placed on regular nebulization schedule with Ventolin and normal saline nebulization every 4 hours to help with bronchodilation, reducing airway resistance, and improving airflow. Also, atropine, Ventolin, and normal saline every 8 hours, in addition to bronchodilation, which is actually atropine help to reduce excessive secretion, which can be beneficial in patients with significant mucus production or airway hyperactivity. And then chest physiotherapy also continued to add secretion clearance and improve lung function. Overall, his ICU stay focused on stabilizing his breathing, controlling the infections, and optimize his recovery. With this measure in place, he was in good shape for transfer and further rehabilitation in medical ward. All right, next. Medical ward management. After being transferred to medical ward, the patient remained clinically stable. He had no shortness of breath, SOB, or chest pain, and remained febrile throughout. Okay. However, he did report pain over his catheter or continuous bladder drainage, which suggested some irritation or inflammation. His vital sign was stable with a blood pressure 117 over 80 millimeter of mercury, heart rate of 89 beat per minute, a temperature of 36.4 degrees Celsius, and oxygen saturation 96%, while receiving a 40% fraction of inspired oxygen via a venturi mask. On lung auscultation, scattered wheezing sound were heard, indicating persistent airway obstruction or bronchospasm. This suggested that he still requires ongoing respiratory support. And then to ensure proper management, several steps were taken. Since his culture result remained negative, he was continued on a 7-day course of IV augmentin 1.2 gram 3 times daily to complete antibiotic therapy for any possible bacterial infection. Chest physiotherapy was also continued to have clear airway infection, secretion, and improved lung infection. Oxygen therapy was maintained with 40% of FiO2 via a venturi mask to prevent carbon dioxide retention while ensuring adequate oxygenation. And as the patient was clinically stable, oral intake was allowed to monitor, and then to monitor his metabolic status infection marker. Blood investigation was ordered, including arterial blood gas, and to analyze and assess his acid-base balance and oxygenation. A complete blood count, CBC, to check any sign of infection or anemia, and a renal profile to evaluate kidney function. Since he had a discomfort over his continuous bladder drainage catheter, he was planned to replace with pulse tube to improve drainage and reduce irritation. His blood glucose level were also monitored for time daily due to the risk of stress-induced hyperglycemia. For airway management, he received a regular nebulization therapy with Ventolin and normal saline nebulization every 4 hours, and atropine, Ventolin, normal saline nebulization every 8 hours to maintain bronchodilation. Additionally, his antiretroviral therapy was continued without interruption, as stopping it could compromise his immune function. At this stage, the focus was on supporting his recovery, optimizing his respiratory function, and preparing him for discharge once he was stable enough. Day 2, on the second day of admission, the patient continued to show improvement. He remained febrile with no tachypneic and was able to speak in full sentences, although his voice was slightly raspy, likely due to recent intubation and airway irritation. His vital sign was stable, with a blood pressure of 106 over 63 millimeter of mercury, heart rate of 75 beat per minute, temperature 36.5 degrees Celsius, and oxygen saturation 99% while on venturi mask, delivering 40% of oxygen. Lung auscultation revealed only minimal bronchi, suggesting that his airway obstruction was improving. The ATT tube and sensitivity test shown no bacterial growth and blood culture was sterile, ruling out concern of secondary bloodstream infection. Given this improvement, the normalization frequency was adjusted with atropine, Ventolin, and normal saline reduced to every 12 hours. And Ventolin with normal saline reduced to every 6 hours to prevent unnecessary medication exposure while maintaining airway support. IV augmentin was continued for full 7 days course to ensure adequate bacterial coverage. Potassium supplementation with mixed potassium chloride at dose of 15 millimeter 3 times daily was maintained, but with strict monitoring to prevent hyperkalemia and was to be withheld if potassium level exceed 4.5 millimole per liter. IV hydrocortisone at 100 milligram 3 times daily was continue to control airway inflammation. Due to his improved oxygenation, a winning trial to nasoprong oxygen at 3 liters per minute was initiated. Additionally, pulse tube was removed as the patient continuous bladder drainage related symptom had resolved. Overall, by the second day, the patient was showing steady progress and he remained hemodynamically stable. His oxygenation was improved and airway inflammation was under control. The focus of management was on reducing unnecessary intervention, maintaining infection control, and gradually weaning him off oxygen and medication as tolerated. Okay, for on the third day of admission, patient all right, this is, let's go to the day 4. On the fourth day, the patient was doing really well. He had completed his 7-day course of IV amantine, so his pneumonia was fully treated. His sputum tests for acid bacilli were negative, which means tuberculosis was unlikely. He wasn't having any fever, was breathing comfortably on his own without oxygen and looked much better overall. His vital sign was solid. Blood pressure was 102 over 59 milliliter of mercury. Heart rate was 76 beat per minute. Respiratory rate was 19 breath per minute. Temperature was 36.7 Celsius, and oxygen saturation was 97% on room A. His lung sounds completely clear, with no wheezing or ronchi. It was safe to stop his nebulization therapy. Since everything was going well, they prepped him for discharge. He was scheduled for a follow-up at Clinic Kesehatan in a week just to make sure he continued doing well and to monitor for any infection disease concern. They also took blood sample to check his glycated hemoglobin to assess his metabolic control and arrange a tuberculosis culture just to be extra sure. For his potassium level, he was given slow release potassium chloride 1.2 gram twice a day for 3 days to prevent any dips. As for his asthma management, they adjusted his inhaler. He was prescribed salbutamol 2 puffs 3 times a day for 3 days, then as needed. The seretide Evohela 25 mic salmeterol and 125 mic of fluticasone, 1 puff twice daily to help keep his airway under control. And then they also book a follow-up at medical outpatient department at HUS in a month. Okay. And then pre and post bronchodilator lung function. So a takeaway from this case is that this case really show how tricky thing can get when someone with asthma pneumonia also has a weakened immune system due to retroviral disease. A lung infection on top of that already compromised immune system can seriously mess with breathing and make airway congestion more worsen. This 26 years old came with severe breathing issues, and despite getting ventilation, steroid, and antibiotic, his high CO2 level and respiratory failure barely improved at first. He ended up needing 4 days in ICU, where ventilator support and careful infection management finally helped. Once he was stable enough, he was extubated and moved to the medical ward for continued oxygen therapy, nebulization, and chest physiotherapy to help clear his lung. The big takeaway here is recognizing respiratory failure early in patients with immune system issues is very crucial. They need aggressive and well-rounded treatment, including ventilation, strong bronchodilator, steroid, and the right antibiotic. Getting on top of things fast can prevent complication and really improve the chance of recovery. At the end of the day, this case is a very great example of how personalized and comprehensive care make all the difference when managing severe respiratory problem in immunocompromised patient. So this is my reference. So any question? All right. What is CD4? Oh my God, it's very difficult. Okay, try. CD4 stand for cluster differentiation 4, uh, which means refer to the type of white blood cells that are called a T helper cells. These cells play a very crucial role in the immune system by coordinating the body response to infection. For HIV, CD4 are especially important because HIV specifically target and destroy the CD4. As the virus progresses, the number of CD4 cells decreases, weakening the immune system. A normal CD4 range between 500 to 1,500, if I'm not mistaken, cells per cubic millimeter of blood. When the CD4 drop below 200, is what I know, a person will be diagnosed with AIDS, which significantly increase the risk of severe infection. Okay, doctor will monitor the CD4 to assess how the immune system is functioning and to guide the treatment decision. Okay, is that okay? Okay, the next second. Okay. All right. Imagine that you have a patient with acute exacerbation of bronchial asthma caused by CAP, also have RVD. Okay. Now, why do we need to check their liver function test? That's the question, right? First, since the patient has RVD, we need to be aware that both HIV itself and antiretroviral therapy can affect the liver. Okay, some antiretroviral therapy, or we call it ART drug, can be toxic to the liver, and HIV on the other side can cause chronic liver inflammation. So it is important to keep eye on the liver function. Second, let's think about the medication that we might be giving to this patient. They be they they likely to be antibiotic for the pneumonia, possibly bronchodilator for the asthma, and maybe even steroid. And all of these drugs can put extra stress on the liver. In some cases, they can cause drug-induced liver injury. Okay, and then so checking the liver function test help us to catch early signs of liver problem. Third, if this patient CAP is severe, there are risk of sepsis or widespread of infections in the body. Sepsis can affect the liver, leading to something we call a shock liver or sepsis associated with liver dysfunction. So if the liver starts failing, it can make the overall condition worse. So we need to monitor it. Sorry. Another reason to check liver function test is that HIV patients are more prone for opportunistic infection like tuberculosis or fungal infection, uh, cytomegalovirus or CMV, which can also affect the liver. All right. Okay. Okay. All right. I think that's all from me. Thank you.